Hello, am I audible? Hello, okay. So good evening, everyone. Today, in case-based discussion, we will discuss about how to approach a child with upper airway obstruction. So let's start with the first case scenario. So here is a 1-year-old male child with history of cough, cold since 2 days, fever since 1 day, and noisy breathing since last 6 hours. Child is crying but consolable, and there is a history of decreased feeds. So this is the history given by the mother. And on initial impression, child is crying, irritable but comfortable mother side. There is tachypnea and there is audible stridor. Child looks pink, peripheries are pink. So what is your initial impression here? What do you want to do whenever you see a child like this in ER? So any child presenting with stridor, definitely sick child. So here, start the child on oxygen. So let's go to primary assessment. So airway is maintained and tachypnea with suprasternal attractions, nasal flaring. There is audible stridor. Sorry. And circulation wise, there is tachycardia, but otherwise peripheries, BP, everything is normal and child is febrile. Sensorium is normal. So what is your intervention you want here? Hello? Hello? So this child presented with stridor, some respiratory distress. Hello?
Suspecting laryngitis, laryngobronchitis.
Okay. So from yes, it could be a possibility. So from initial impression, from primary assessment, what do you want to do? So already you started the child on oxygen. So there is
Calm the child. Upper airway, calm the child first. Otherwise,
yes. Always try to keep the child like normal, comfortable. Let the child be on mother side. What else you want to do?
if in case of stridor, suspecting adrenal ablation can be started.
Okay. So let's so at the end of primary assessment, like the child is having upper airway obstruction. So I'd like to keep the child on the mother side. Start oxygen, preferably give oxygen to like mother, oxygen tubings to mother and ask her to keep it near child's nose. And never try to cannulate or try to get blood sampling like immediately. Try to calm down the child first, take care of the airway, then collect the blood sample. And preferably, seniors should attend the child and try to minimize the number of pricks. So what could be the possible DDs with this presentation?
Laryngotracheobronchitis, foreign body.
Yes. Could be a foreign body or laryngotracheobronchitis. We have discussed so much about how to manage the child, like in the previous slide, like keep the child comfortable, like don't force oxygen mask, don't give him more number of pricks, or don't be in a hurry to secure a cannula. Why you don't want to irritate the child? What is the reason?
If we irritate the child, the chance of airway collapse will be more, ma'am. The child will go into more laryngeal spasm.
Definitely. So let's see why. So this is a diagram showing cross section of the trachea. So this is infant trachea and this is adult trachea. So diameter of the adult trachea is more, like the lumen diameter is more compared to infant. Whenever there is a edema due to any cause, say like this child we are suspecting laryngotracheobronchitis. So this child has laryngeal edema. So here, because of the edema, there is a significant decrease in the circumference. But in adult, the decrease in the circumference is less because the luminal diameter is more compared to infant. And all of you know Poisson-Lee equation, right? So where it says resistance is inversely proportional to radius to the power of 4.
4.
Yes. So the more the radius decreases, proportionately the resistance increases. So any child with any child with upper airway obstruction, if you irritate the child or child becomes agitated, cries, there is a chance of sudden airway collapse, which is less in adult because of more luminal diameter of the trachea. So what are the causes of upper airway obstruction? So what are the infectious causes?
Tonsillitis.
Diphtheria,
Yes.
Bacterial tracheitis,
Yes.
Friedrich's angina.
retropharyngeal abscess, parapharyngeal abscess.
Yes, exactly. So we can divide into infectious and non-infectious. As we all told, causes of infectious are croup, acute epiglottitis, bacterial tracheitis. These all comes under infectious causes. And chronic causes are your adenotonsillar hypertrophy and chronic tonsillitis. So what are the non-infectious causes of airway obstruction, upper airway obstruction?
Foreign body, any
Foreign
vascular
body.
rings,
Yes.
and any toxic inhalation like burns,
Angioneurotic edema. Burns, trauma, vocal cord paralysis, and your vascular ring, as you told, and tracheal or subglottic stenosis, dysmorphic syndromes, and laryngomalacia. So this child, what are the possible DDs?
croup,
Croup is the first possible DD. With that history, can you rule out foreign body aspiration?
yes, madam.
We can't rule out because mother is telling there is sudden onset of stridor. So what do you want to do to rule out foreign body aspiration, or what investigation you want to do?
Yeah, chest X-ray to rule out any collapse, sudden collapse of the lung.
X-ray chest and neck. So this is the X-ray of the child. What is the sign you are seeing?
Steeple sign.
Steeple sign. What is steeple sign?
Narrowing of proglottic part.
Narrowing of the airway. Your inverted V sign or steeple sign is seen in croup. So how do you like to manage this child?
First, calm the child in the mother's lap, give oxygen,
Hmm.
and adrenal nebulations, 5 ml.
What is the dose of adrenaline nebulization for group?
Undiluted 5 ml. 1:1000 dilution. 5 ml.
For any child of any weight, you
Yes.
only give 5 ml.
Yes.
So safe child present with mild symptoms like comfortable only while like feeding child, like mild group. How do you manage the child?
Steroid should be given.
Yes, we can try oral steroids. What is the maximum dose of dexamethasone?
10 mg. 8 to 10 mg.
8 mg. So as per guidelines, we can give up to a maximum dose of 8 mg of dexamethasone. So if the child is less symptomatic, like say mild group, we can try oral steroids, mild to moderate symptoms. So for adrenaline dose, as per guidelines, it is 0.5 ml per kg. Maximum dose is 5 ml of 1 in 1000 dilution of adrenaline.
For all age groups, it's 5 ml only number. But if it is severe group, irrespective of the dose, you should not go with those.
Any guidelines like?
Yes, I read in one guideline. Some Paediatrician, Jayashree madam article.
Okay. We'll go through the other guidelines and tell, but this is also as per IAP guidelines also. This is same dose, that is 0.5 ml per kg. If it is less than 5 ml, they say dilute it with NS to make it a volume of 5 ml and give nebulization. So maximum dose is 5 ml. So let's go to the second case scenario. So here is a 3-year-old male child with complaints of cough and cold since 1 week, fever since 3 days, refusal to feeds and pain during swallowing since 2 days, and drooling of secretion since 1 day. So on initial impression, child is irritable, sick looking, with drooling of secretions from mouth. Child is pink with breathing wise, he is having tachypnea. So on primary assessment, child airway is maintained, but he is comfortable lying in leaning forward position, lying on mother's chest, and there is significant drooling of secretions. There is tachypnea with suprasternal and retractions and nasal flaring, but air entry appeared good, and saturations are around 95% at room air. And circulation wise, except for some tachycardia, pulses are well felt, CRT is normal, BP is normal, and child sensorium is also almost normal except for that irritability, and child is febrile. So what do you like to do here?
Just calm the child first.
Like any child presenting with upper airway obstruction, try
Oxygen.
to calm the child, give oxygen to mother and ask her to help. Hold it near child's nose. And only once you are sure that child is comfortable, then only try cannulation.
Examine.
So what are the other findings? There are palpable cervical lymph nodes, and child is having painful neck movements, like he is crying whenever he is attempting neck movements. So what are the possible DDs here?
Epiglottis is my first one. Next one is any retropharyngeal abscess also. One of the reasons.
Exactly. So this is a beautiful algorithm showing how to approach a child presenting with any upper airway obstruction symptoms. So any child presenting with upper airway obstruction, look for any signs of severe airway obstruction. What are the signs of severe airway obstruction?
Stridor, hoarseness of voice, and suprasternal retractions.
They are all already present in this child. In previous child also stridor is present. How do you know this child is going into severe obstruction?
Air entry, reduced air entry.
Air entry will reduce. The child will become more hypoxic.
More hypoxic, cyanosis.
PCO2 retention. there will be decreasing in the consciousness level, like child will become more comatose. There will be decreased stridor. Previously, the child is having stridor because he is attempting to take breathing against that inflamed airway. But now his efforts are decreasing. So there will be decreased stridor, decreased air entry. So all these are signs of severe airway obstruction. So any child presenting with upper airway obstruction, look for signs of severe airway obstruction. There your management will completely differ. So there your main concern is about to stabilize the airway. So any child presenting with severe airway obstruction, call for help immediately. Try to shift the child to OT or ICU. So here our main aim is to secure the airway. So if the child doesn't have any signs of severe airway obstruction, let's see how this child presented. This child has fever, right? And what is the appearance of the child? Definitely child is sick look. Yes. Does this child have any odynophagia and drooling?
Drooling is there, no odynophagia.
Drooling is there, and mother is telling that is decreased feeds. Sometimes he complains throat pain. Yes. So drooling, odynophagia with high-grade fever, toxic appearance, neck pain and stiffness. So we are doubtful about that because whenever child is attempting or when we try to examine, he is having pain. So all these features are hinting towards retropharyngeal abscess. As child is only 3 years old, we don't know whether it is literally like clearly neck pain or not. So epiglottitis could be other possibility. And sometimes parapharyngeal abscess can also present with the similar findings of odynophagia. The child can have high grade fevers. Drooling may or may not be present. So this is a beautiful algorithm. Following this, we can go into probable diagnosis if we follow this algorithm. So where were we now?
Neck pain, stiffness.
Yes, no. What DDs you attain by following this algorithm for this child?
Epiglottitis and retropharyngeal abscess.
Epiglottitis or retropharyngeal abscess. So what do you want to do now to confirm your diagnosis?
X-ray lateral.
So these are our two DDs. So lateral neck X-ray and CT neck. So how will you take lateral neck X-ray to look for retropharyngeal abscess? They say preferably in normal extension during normal inspiration. So what is the finding here?
Hypolution patches in the posterior pharyngeal wall.
Any other significant finding? Is this width normal or abnormal?
Increased.
Increased. What is the normal width?
3 mm.
Any better answer? So the measurement in mm varies with the level of the vertebra. They say if it is at the level of C2 vertebra, the width of the soft tissue, that is between posterior border of your airway and anterior border of your vertebral body. So at the level of C2, it should be less than 7 mm normally. And at the level of C6, they say it should be less than 16 mm. So this is very confusing, right? So to remember, we can remember like this. So at any length of the cervical vertebra, if the width of the soft tissue is more than half of the width of the vertebral body, say if vertebral body width is 2 centimeters and the soft tissue diameter is also 2 centimeters, definitely it is abnormal. Less than half of the width of the vertebral body is normal. So definitely there is an enlargement of the soft tissue width, and there is also some hypolucent patches, maybe probably abscess, indicating abscess. So this child presented, this child We diagnosed it as retropharyngeal abscess and it is confirmed in CT also. So how do you manage this child? What investigations you want to send? So any child manages airway first, then we send counts and CRP, both are elevated, started on IV antibiotics and abscess was drained in OT under anesthesia and post drainage, child is stable. Say for example, while attempting cannulation, this child went into respiratory arrest. Like, how do you manage a child with severe airway obstruction?
Cricothyroidotomy.
Before that, can you try anything? What are the other measures you should take? Any child, whenever you are suspecting impending
Difficult, yeah.
severe obstruction, shift the child to a controlled setting like ICU or OT. Always call for help. Main thing is anticipation. Anticipate severe airway obstruction. Or if the child suddenly went into airway obstruction, call for help and never give sedation to the child because he's like it will further worsen the obstruction. And always attempt intubation by expert like senior, and it should be in a control setting like ICU or OT. And if you are not able to secure airway, always keep things ready for needle cricothyroidotomy. Let's go to the next case scenario. So here is a 15-year-old male child presented with throat pain since 4 days, fever since 2 days, and history of decreased feeding. So this child on initial impression was dull, otherwise looking normal. On primary assessment, airway maintained, breathing almost normal. Circulation wise, there is some tachycardia and child is febrile. Otherwise normal. So on examination, this child has tenderness of the neck on the left side with palpable enlarged and tender lymph nodes. Throat examination showed congestion with findings more prominent on left side with left tonsillar hypertrophy. And there is decreased neck movements on left side because of the pain. So what are the possible DDs for this child?
Tonsil,
Peritonsillar abscess means
Yes. So there is a unilateral findings on throat examination, more prominent tonsillar hypertrophy on left side, palpable cervical lymph nodes. So it could be possibly it could be peritonsillar abscess, or it can also be parapharyngeal abscess. So this child, when we took X-ray, we couldn't notice anything, and CT showed there is a left parapharyngeal abscess. How do you manage this child? So we started the child on IV antibiotics, and the abscess size is 2 into 1 centimeter, and slowly abscess size started decreasing. Child become febrile. And once there's a significant reduction in the size of the parapharyngeal abscess, we discharged the child on oral antibiotics. Coming to next case scenario, like this is a hypothetical scenario. You are called by your neighbor asking for help. So their 9-month-old child suddenly started noisy breathing, cough, and struggling to breathe. Mother also told you that child was playing with a toy and they found that small button battery was missing. So how do you manage this child?
Immediate removal.
Back thrust for 5 times and CPR for 5 times.
Back thrust and chest compression.
When we will give back thrust and chest compression?
Less than 1 year child.
So you should see whether it is partial obstruction or complete obstruction. So this child is, we are able to listen some voice, he's trying to coughing, like he's trying to cough. So definitely this is partial obstruction. Any child presenting with partial obstruction, try to shift the child to a hospital as early as possible without like irritating the child much, like without try to keep him calm and shift the child to emergency as early as possible. So whenever you are not able to listen any voice from the voice from the throat, and there are like doubtful foreign body aspiration, then we can go for your back blows and chest thrusts. Until how long you will give back blows and chest thrusts?
Expulsion of foreign till expulsion.
Till your foreign body comes out or until the child becomes unresponsive. Once the child becomes unresponsive, what you will look for?
Start CPR.
You should check for pulse, and if the child is in cardiac arrest, start CPR. So take home message from this class is like to identify upper airway obstruction. So whenever you saw a child with the upper airway obstruction, take all the steps to prevent the child to go into severe airway obstruction. And whenever you are anticipating severe airway obstruction, shift the child to tertiary care center or ICU or OT as early as possible. And all of us should know how to do needle cricothyrotomy also. How will you do? Because it's an emergency life-saving procedure. So I don't know the exact guidelines for needle cricothyrotomy, but what we follow is we use an orange color cannula. To that, we'll fit a 3.5 ET adapter. 3.5 ET tube adapter will fit into this orange color cannula. So with that orange color cannula, we can do needle cricothyrotomy and connect oxygen to that. This is what we follow in our unit. Any doubts?